Hello and welcome back to Neurosensory for Clinical Cases. Today it's part 4 and it's the final instalment of the Neuro for second years, and we're going to be looking at the final 9 cases which we were taught about. So those are thyroid eye disease, cranial nerve abnormalities, disorders of the ear, dizziness, light-headedness, schizophrenia, depression, headache, diabetic neuropathy, and aphasia, both Broca's and Wernicke's. So let's begin. First of all, we have thyroid eye disease, which is when the muscles and the fatty tissue within the eye socket become inflamed and swollen, and this pushes the eyeball forwards and affects the eye movement. Normally it's associated with hyperthyroidism, particularly Graves' disease. However, this isn't always the case. It doesn't have to have a direct link to some kind of hyperthyroidism. In terms of clinical signs that you'd be looking for in a patient, you'd expect them to have retraction of an eyelid in 90% of patients, and also restriction of eye movements is also quite common due to the eye being pushed forward. Therefore, as a patient, they may experience a feeling of grittiness in their eyes, they may have dry or watery eyes, they may have a dislike of bright lights, and also a feeling of fullness or swelling in the eyes. In terms of treatment for this case, there are quite a few options you can go down. So surgery can help most severe forms. Also decompression surgery is quite commonly used in order to create more space behind the eye, which is when it's putting pressure on the nerve, on the optic nerve. And also in mild cases, it's not always necessary to have any kind of surgery. Simply drops for your eyes will help your eyes feel more comfortable. Moving on, we look at cranial nerve abnormalities. So these are trigeminal neuralgia, facial nerve palsy, so Bell's palsy, and also eye disorders such as nystagmus. First of all, if we look at trigeminal neuralgia, so the trigeminal nerve is cranial nerve number 5, and it's the largest of the cranial nerves. It's got 3 branches. The first one is ophthalmic, the second one is maxillary, and the third one is mandibular. The ophthalmic and maxillary are both sensory, and the mandibular is both sensory and motor. Trigeminal neuralgia is a neuropathic disorder where there is intense facial pain for the patient. It could encompass 1 branch, 2 branches, or all 3 branches of the trigeminal nerve. And the nerves carry that sensory information of pain, temperature, and pressure. Moving on, you can look at Bell's palsy, which is an issue with the 7th cranial nerve, the facial nerve. And this nerve emerges from the pontine medullary junction. It's got control of the facial expressions, the muscles of facial expression. It controls taste for the anterior 2/3 of the tongue and the oral cavity, and also it provides parasympathetic fibers to the head and neck. However, in Bell's palsy, we have an unknown dysfunction of the nerve, which can appear simply overnight. It can cause facial drooping with the inability to close the affected eye, and also drooping of the corner of the mouth, so reduction in the muscle tone there. Moving on, we can look at cranial nerve number 3, so disorders of the eye. So we can look at cranial nerve number 2 and 3 here really, but cranial nerve, the oculomotor nerve, cranial nerve number 3, is the most commonly affected. And nystagmus is a condition which causes constant involuntary movement of the eyes which you can't control. Moving on, we look at disorders of the ear. Now the ear can be divided up into outer, middle and inner ear. It's a little bit difficult to see on this slide, however there is a diagram down at the bottom here which shows the segmentation of the ear into outer, middle and inner, and this might be quite useful in terms of visualizing where these disorders happen. So the outer ear, this is what you can see visually, plus the external auditory canal up until the tympanic membrane. The middle ear refers to the tympanic membrane plus the auditory ossicles, so the bones, so the incus, the stapes and the malleus. And then lastly, you've got the inner ear, which is composed of the vestibule and the cochlea. So in terms of disorders of the inner ear, the one you really do need to know the most about is Meniere's disease. It's a disorder of the endolymphatic system characterized by distension of the membranous labyrinth due to increased volume of endolymph. Okay, and the symptoms come really in 3, so vertigo, tinnitus and ear pressure. Obviously be aware of the damage that trauma, degenerative diseases and ototoxicity can cause. Disorders of the middle ear, the one you really need to be aware of is this one here, cholesteatoma, which is a sac-like structure lined with keratinized squamous epithelium, and it can cause bone destruction and hearing loss. Finally, the outer ear. The main one you need to be aware of is otitis externa, also called glue ear. This is an inflammation of the ear canal. It often presents with ear pain, swelling of the ear canal, and occasionally also decreased hearing. Moving on, we have dizziness and light-headedness. So dizziness can be split into 4 distinct categories. So you've got vertigo, disequilibrium, pre-synecope, and light-headedness. Okay, the 4 kind of subheadings which you would expect under dizziness. But what are the causes? So they're the main things you really need to know about. So low blood sugar, hypoglycemia, causes a patient to feel hungry, trembling, or feeling shaky and sweating. And in severe cases, they may lose consciousness. Treatment, very simple, drink or eat something sugary. Dehydration or heat exhaustion, when the body doesn't have as much fluid as it needs, this obviously disturbs the balance between salts and sugars, which then affects the way the body functions. Symptoms, obviously the patient will feel thirsty, lightheaded, and also they'll pass dark-coloured, strong-smelling urine. And in terms of treatment, again, drink plenty of fluids. In this case, however, try to avoid caffeine or fizzy drinks, and sipping would be best. Get it into the system slowly. Another cause is postural hypotension, so low blood pressure, and this can be affected with dizziness after changing positions, such as standing up. And this is actually more common in elderly people. So symptoms here: dizziness, loss of balance, fainting, blurred vision, and also rapid and irregular heartbeats. The last cause we're going to explore is vestibular neuritis. So this is a viral infection of the inner ear, and some people think that this is actually specifically to do with the nerve cells of the inner ear. It's usually viral, and therefore it comes with a sudden onset of dizziness with a spinning sensation, also called vertigo, accompanied by nausea, feeling sick, and general unsteadiness. Patients who present with this really will have probably more severe symptoms in terms of with their vision, hearing, and concentration, and lightheadedness will just be one of their several symptoms. Moving on, we looked at schizophrenia. So this is a psychotic condition, and psychosis we can define that as a mental health problem causing sufferers to perceive and interpret things differently to those around them, and it affects around 1% of the population. It's a mental disorder, schizophrenia, and it causes abnormal social behaviour and a failure to differentiate what is real and what isn't. You can divide the symptoms into positive and negative, so positive being those such as delusions, hallucinations, and also rarely catatonia. Negative symptoms, you'll be thinking about apathy, withdrawal into themselves, and reduced motivation or poor attention spans. In terms of causes of schizophrenia, this is quite arguable. In terms of genetics, that certainly plays a role because your risk increases if a certain family member has schizophrenia. Also, it could be psychological, so due to double-blind or schizophrenic mother. And also influenza apparently is also a linked cause, so increased association in spring births. However, an actual gene for schizophrenia has never been identified, and most people like to fit this into the vulnerability model, which refers to a mixture of environmental challenges with a genetic vulnerability causing a patient to develop schizophrenia. Moving on, we have depression, and there are many types of depression with innumerable causes. Apparently around 5% incidence and 20% lifetime prevalence for unipolar depression. So it's a low mood essentially that lasts for a long period of time. Really, depression doesn't stop you leading a normal life. However, it can make some more day-to-day tasks for some people more difficult to complete. And again, here we can define the symptoms by either looking at biological symptoms or psychological symptoms. So biological symptoms are those such as sleep problems, reduced appetite, weight loss. Psychological symptoms are those such as low mood, tearfulness, thoughts of self-harm, anxiety, and irritability. Probably those that are probably slightly more noticeable to people who the sufferers are spending time with. Theories of the cause, so theories being the key word here. There's quite a few different theories which you can explore for yourself, but more importantly, a lot of people believe it's due to psychological causes, things that kind of happen to a person in their life, and how this can therefore lead to almost a spiral of depression. In terms of treatment, antidepressants are a key treatment here. There are several types of antidepressants which were covered in a therapeutics lecture a little while back, and these can be divided into first generation and second generation antidepressants. But probably the one to be most aware of are SSRIs. These are the first line drug that we use, and an example of these are fluoxetine. Next we have a headache. So a headache is quite a simple term, but everyone really knows what it means. But really it can be divided up into primary and secondary headaches. So primary headaches are those such as cluster headaches, which are come on quickly. It could also be a migraine, a tension headache, which are bilateral with pressing or tightening to the skull, but no nausea associated with those. And also with primary headaches, there's no associated pathology. With secondary headaches, this is probably a more serious form of illness, so it could be linked to a neoplastic condition, so raised intracranial pressure. It could be due to a central nervous system infection, such as meningitis, or it could be drug-induced or trauma even. In terms of headaches, we need to be aware of red flags. So red flags are basically the more severe problems that can be associated with a headache. So sometimes a headache can simply be a symptom of a condition such as a stroke, meningitis, or a brain tumour. So if people describe the pain as blinding pain, or if it doesn't get worse or doesn't go away or progressively gets worse over time, it occurs after a head injury, or it's triggered by something such as coughing, laughing, sneezing, then therefore these would all be red flags in terms of clinical treatment. In terms of management of a headache, obviously a lot of people do take paracetamol, ibuprofen in order to manage the pain as such, but really the most effective treatment really is to rest in a quiet, dark room, remove any glasses or lenses if you're wearing them, and also hot and cold compresses can be helpful. Diabetic neuropathy, so this has an incidence more common in people with poor control of their diabetes, who are overweight and have higher levels of blood fat. It occurs in up to 50% of people who are suffering from diabetes, and it causes numbness and potentially pain, and this usually starts in your hands and arms and progresses over time. A little thing to be aware of as well is this box down in the corner, so types of neuropathy. This isn't particularly 100% linked into diabetic neuropathy. However, peripheral neuropathy is the most common type of diabetic neuropathy, but it's worth being aware of these different forms here. Moving on to our final topic for this video, it's aphasia. So aphasia can be in the form of Broca's or Wernicke. So if we think about general causes of aphasia, these could be down to stroke, transient ischemic attacks also. It could also be down to neurodegenerative disorders such as Pick's disease or Alzheimer's disease. Could be due to viral encephalitis or also MS, but this is significantly more unusual. If we split this into two, so Broca's, we're thinking about a motor speech problem, because Broca's is a motor speech area. It's involved in the formation of words. So Broca's area is located in the frontal lobe of the brain, and it helps with that movement required to produce speech. So therefore, in a patient with Broca's aphasia, you'd expect them to fully be able to understand everything you're saying, but have difficulty replying to you. In a patient with Wernicke's, so Wernicke's area is a sensory area, and it helps with the understanding and comprehension of speech, and therefore using the correct words to express thoughts. It's located in the parietal and the temporal lobes, so therefore a person with Wernicke's aphasia would find it very easy to speak and communicate. However, they would have a massive difficulty in terms of understanding others. Speech therapy is usually the way to go with Broca's and Wernicke's. Sometimes no treatment's needed. It doesn't always have to be permanent, this aphasia. It sometimes can get better. In terms of clinical medicine, it's always really important to remember that a patient with Broca's aphasia, despite not being able to properly communicate what they're thinking, they're just as intelligent as before the aphasia began, and therefore it's just a difficulty with expressing what they want to say. That's everything for neurology in terms of clinical cases. If I have missed any that are blindingly obvious, please do let me know, and I will either try to catch up and do a little other video if I've missed quite a few, or happily provide any information on any I have missed. In the meantime, if you do have any feedback, any questions, any suggestions, that would be greatly appreciated. But that's all now until we move on to the urogenital system. Thank you for listening. I appreciate it, and thank you for all the support.